So next we're going to have some fun. So we like debate in all countries in the world, and so we thought we'd stay away from a political debate and stick with IPAF. Is this an entity of its own? And who better to kick us off with the side than Sonye Danoff? No pressure there, Sonye. And she is from Johns Hopkins University and lots of experience in this area.
All right. Well, thank you very much to the organizers for inviting me to participate in what is a very it has been a very interesting summit, and obviously this is an area, the connective tissue disease, ILDs, that's near and dear to my heart. Now, interestingly, my task today is to talk about whether interstitial pneumonia with autoimmune features, or IPAF, is an entity unto its own, and I'm the pro speaker. So just to disclose the fact that I have no financial conflicts of interest, and I'm not going to discuss any medications in the talk. And I'll remind you what Romeo and Juliet said, that which we call a rose by any other name would smell as sweet. Now, when we were thinking about this pro-con debate, I knew that I was giving one of the talks, and I understood that my colleague and friend Justin Oldham was going to give the other talk, and so Justin is a very organized person, which I admire about him, and so he sent a note to Mary Streck and me, and he said, I hope you're doing well. I'm going to be in this debate. After turning in my slides, I decided to check on who the other half was, and I saw it was Sonye, and I realized that my assumption that he was supposed to be giving the con was actually incorrect. And he said, don't worry about it. If there's a problem, just let me know. I'll send you my slides. And so what I said back to him was, this is also news to me because I thought I was giving the con. But I'd be happy to give the con side also and see if anybody else notices, and if not, I'll talk about the pro side. So what I'm going to do today is I'm going to stand in and try to channel R.A. Fisher. My objectives in this are to define interstitial lung disease with autoimmune features, which I think many of you are very familiar with. And I want to talk about the context in which the entity was developed, because I think that that's actually really the critical issue in thinking about whether this is actually a unitary entity. And then I want to talk about how this entity can be used in moving research forward in autoimmune disease. So really, the history around this goes back to about 2007, and there were a number of publications that talked about interstitial lung disease or interstitial pneumonia. That was the only sign or the presenting sign of autoimmune disease. And the reason why this was important is that everybody who noticed this, and I think many people had commented on it clinically, but now it was being published on, everybody chose a different name. Somebody called it an autoimmune feature, somebody called it an undifferentiated connective tissue disease, ILD. But the reality is that everybody was really talking about the same thing, that they were using different names. So at about that time, the American Thoracic Society and European Respiratory Society said, hey, you know what? It's really important, since this seems to be an issue that people are talking about, we need to actually kind of create some guidance about it. We don't want people calling it 25 different things, and then we can't quite figure out if we can compare it. So they set up this task force on undifferentiated forms of connective tissue disease-associated ILD. And the purpose of this was to develop a research statement. And I have that bolded and underlined because that is the important point. This is a research statement. And it was to develop consensus around a nomenclature and classification in patients who have suggestive forms of connective tissue disease associated with interstitial lung disease. Okay, so why does this happen? Well, we've heard a lot about antibodies today. We've heard about interstitial lung disease. And what we recognize is that there were a large number of patients who presented with interstitial lung disease who might well have autoimmune disease or connective tissue disease as the etiology, but that for reasons that I'm going to discuss in a minute, they didn't actually fall into a described category, that we couldn't label them as having a specific connective tissue disease. And so this group of patients was the ones that was really the group that needed to be addressed. So subsequently in 2015, with a lot of people who were in this room and at this table involved, there was an official ERS-ATS statement. And I'll just again point out it's a research statement on interstitial pneumonia with autoimmune features. And any of you that was paying attention will notice that that term is entirely new. That IPAF term was actually created as a part of this consensus statement. Okay, so what was the classification? Well, the idea was that you essentially had a couple of different features. So one of them was that you had interstitial pneumonia or interstitial lung disease, because that's what we were interested in, that we had excluded other etiologies, which is very interesting given the conversation about silica and the potential role that silica is playing in the presence of autoimmunity, and that it does not meet the criteria of a defined connective tissue disease. So you saw in Dr. Streck's talk a recent description of what the classification of scleroderma is. And she pointed out that although lung disease is incredibly common in autoimmunity, most of the rheumatologic organizations have not included interstitial lung disease as a defining characteristic. And then you had to have at least one of these domains, a clinical domain, a serologic domain, and a morphologic domain. So the key is it did not meet the criteria of a defined connective tissue disease. And again, I'm going to kind of come back to this one more time a little bit later on, but that was the key criteria. It did not hit the button for meeting enough numbers to hit a scleroderma diagnosis or rheumatoid arthritis diagnosis or any of these other specific connective tissue disorders. And so the clinical domain included many of the features that we commonly associate with the presence of a specific autoimmune disease. So distal fissuring, mechanics hands, which we often associate with dermatomyositis, inflammatory arthritis, which we might associate with rheumatoid arthritis, palmar telangiectasias, which we associate with scleroderma and Raynaud's, and so on and so forth. So any of these features that clinically we associate with specific autoimmune diseases, if they were present, but there wasn't enough of the other features to make the diagnosis, that would put it into the clinical domain. And then the serologic domain, which included a very wide variety of different antibodies, including high-titer ANA, double-stranded DNA, and then things like the tRNA synthetases, which are considered to be the myositis-specific antibodies. So it's a very wide range of serologic descriptors that could meet the classification in the serologic domain. And then finally, the last domain was essentially a histopathology domain, and those could be essentially any pattern on HRCT except a UIP pattern, or a biopsy that had any of these other features except UIP. And again, we can argue about why that was chosen. And then finally, any sort of multi-compartment involvement. So in other words, if the pleura was involved, as you saw in the image that Dr. Streck showed with the pleuroparenchymal fibroelastosis. So basically it was choose one from each of these columns, and the patient can't meet a defined criteria, and the patient will be called IPAF. Okay, so here is what IPAF is, and I do believe IPAF has a purpose and is an entity, but it's a construct that was made up for research purposes. It was never intended to be a clinical diagnosis. It assumes that there's an extremely high level of certainty in the current CTD classification system, and I think that there are many of us in this room who probably feel that the makeup of these diagnostic criteria are probably a little bit outdated, and that clearly, because we know that interstitial lung disease plays a major role not only in morbidity but mortality in many of the autoimmune diseases, it seems sort of unreasonable that it isn't part of the classification scheme. And the other thing that IPAF does is it puts together things that are very common, like ANAs, with things that are fairly rare, like antisynthetase antibodies. But IPAF really exists because current CTD diagnostic guidelines are incomplete. And as those guidelines become updated and recognize and include the presence of interstitial lung disease as a cardinal feature of autoimmunity, then I think that this entity may well not need to be. So what IPAF is it's not a clinical diagnosis. It does not have a biological basis, at least as far as I can tell, and there may be some in the room who would like to argue with me about that. And actually, at this point, I think it has no therapeutic implications either. So I think that we still need to think about this as a research designation to try to help us understand this group of patients for whom the lung is the dominant feature in what appears to be an autoimmune process. And so how can we use it? Well, we want to try to bring together serology and clinical phenotypes. I think that the advent of serology has been really a game changer for the field of rheumatology, and should be for us as well. I think that we really need to focus on the lung as a primary end organ in connective tissue disease. And then I think we need to compare cohorts of IPAF with those that have more traditional organ presentations, and I think you'll hear a little bit about that. And I think that using IPAF is really a reminder that we don't know, and that a name can be really an insignificant feature. And so with that, I'm going to end and turn it over to my friend and colleague and debate partner, and have him present the other side of the story.
Thank you, Sonia, and thank you to the PFF for inviting me to give this talk. There it is. So my name is Justin Oldham. I'm from UC Davis. And Sonia gave you some background, and as she implicated or alluded to, I have a pathologic aversion to deadlines, and so I tend to turn slides and grants in 4 to 6 weeks early. And so it was really out of fun that I was eagerly anticipating who was going to be giving the other half of this debate, and so this is part of the reason we both assumed that we were going to be giving the no, which is this counterpoint that we published in Chest with Ari Fisher and Joyce Lee giving the pro. And so Sonia was gracious to allow me to give the con part, which we had developed quite extensively in this pro-con debate in Chest. So the short answer to this question is this a distinct entity, and not even close? And I don't mean to say this to discount the idea of IPAF. I actually fully support IPAF, and it's easy to break something down, but it's a lot harder to build it. And so I think people like Ari Fisher, Joyce Lee, Mary Streck deserve a lot of credit for building this idea, because until we all speak the same language, we can't study this entity, whatever it is. And so I'm going to revise that to at least not yet, because I think we are moving in the right direction. I think we're going to get there eventually, as to making this more of a homogeneous, not just research classification, but even a diagnosis. So here's some disclosures that are not relevant to this talk. I'm going to touch on 3 particular features that make this not yet a distinct entity, which is inhomogeneity among the IPAF subgroups has already been demonstrated. So we already know that this is not a homogeneous group. There's a good degree of selection bias, which is really influencing the studies that have been performed to date. And missing data are a huge, huge limitation in any sort of IPAF research that's being done right now. So getting to the inhomogeneity, we'll start with the morphologic subgroups. As Sonia showed you, these are the subdomains making up the morphologic domain. And as we can see here, we have NSIP, organizing pneumonia, some overlap on high-res CT, and then the histologic correlates with the addition of these lymphoid aggregates with germinal centers, along with a diffuse lymphoplasmacytic infiltrate. What you'll notice is missing from this, and appropriately so, is usual interstitial pneumonia. So usual interstitial pneumonia, as we all know, is the radiologic and histologic manifestation generally of IPF. Obviously, we can see it in RA, as Yvonne mentioned. We can see it in scleroderma, as Mary mentioned. But in general, when we see usual interstitial pneumonia and we've ruled out other causes of ILD, we're talking about IPF. And why is that important that UIP is not included in these and, in fact, is excluded? Well, this paper that we published in the ERJ when I was still in Chicago showed that compared to patients with IPF and CTD, those with IPF fell somewhere in the middle, although a lot closer to the IPF survival curve. When we broke that down into patients who had UIP versus something that was not UIP, what we saw was that those who had a pattern other than UIP had a trajectory that much more closely approximated CTD, whereas those with a pattern of UIP had a trajectory that was really indistinguishable from IPF. And so this morphologic inhomogeneity is very important. It really does predict separation in how these patients are how they're gonna do. The next is inhomogeneity among serologic subgroups. And so we all know that ANA and rheumatoid factor is commonly checked in patients. It's commonly positive in patients. It's commonly positive in healthy people out in the community without CTD. And so a positive ANA or a positive rheumatoid factor is a lot less sensitive, specific, important for patients. as opposed to something like a positive tRNA synthetase or a positive MDA5 antibody. So Sonye published a really nice piece in Chest, 10 years or so ago now, essentially saying if you have ILD plus a tRNA synthetase or MDA5, we really should be considering these patients to have an anti-synthetase syndrome. And we've had a lot of data published since this time showing that these patients do have a pretty unique trajectory, and if you get them on treatment early, often they tend to do pretty well. So these are some unpublished data which will be getting submitted shortly, where we took 3 different centers, so UC Davis, University of Chicago, and UT Southwestern. Deji Adegunsaye and Mary Streck were instrumental at Chicago in getting these data, and then Chad Newton at UT Southwestern. And what we did was we aggregated our 3 different IPAF cohorts along with our other CTD ILDs and our IPF cohorts. And what we did was we asked the question, if we segregated out patients with a myositis-specific antibody, or what I call an anti-synthetase antibody here, do they behave differently than other patients meeting IPAF criteria? And what we see here is this is the CTD curve, so we know that those patients with CTD do better than IPF. That's been well documented. These are the IPAF patients here. This is sort of what was shown in our original Chicago paper, which is there is some separation. They do a little bit better than IPF, but not much. What's interesting, however, is if you take the patients with IPAF who have an anti-synthetase antibody or a myositis-specific antibody, those patients do quite well, and they're almost uniformly treated with immunosuppression, appropriately so, because they most likely have myositis that just doesn't meet criteria for myositis. And if you compare them to a myositis ILD cohort, you see that these patients are largely indistinguishable. And this is true not only of the survival curve, but it's true of the various types of clinical features, lung function, morphologic features, high res, et cetera, et cetera. These patients really are indistinguishable. And so for that reason, I feel strongly, and I know others in the field do too, that the tRNA synthetases and probably MDA5 as well probably should be removed from the IPAF criteria. It's leading to undue inhomogeneity in this group and heterogeneity. And it really does support the unified classifications of patients with anti-synthetase syndrome and myositis-associated ILD together, not only for research but also for clinical trials. All right, so next is selection bias. So who's the screening population? The 2 studies that are often brought up when having this discussion was the study that we published in Chicago and the study led by Ari Fisher, Joyce Lee, Sandra Charton at Denver. And these have been sort of held up as 2 examples of IPAF because of the diabolically opposed results that we have. And so there's a reason that we have very opposing results. First is in the Chicago cohort, what we did was we applied IPAF criteria systematically to our IIP cohort. So very unbiased. If you had IIP, including IPF, idiopathic NSIP, organized pneumonia, we had no pretest probability of having CTD. We just uniformly applied them and saw what shook out. In the Denver cohort, they drew their patients primarily from a rheumatology clinic who had ILD expertise. And so already these patients who are being referred to this rheumatology clinic probably had a higher likelihood of having occult CTD, or they wouldn't have been referred in the first place. That's my impression. RA may have a different opinion on that. So as I showed you here, our apple to their orange is that IPAF really isn't all that different from IPF, and some of that is driven by the UIP that I showed you earlier. But at least when you apply IPAF systematically to patients with IIP, they tend to look mostly like IPF. Contrast that with the orange of the Denver cohort, which is not a survival curve. This is just a longitudinal plot of FVC over time. And the reason that they do not have a survival curve is because their mortality was 0% in their cohort as compared to ours, which was a quite high mortality. And what they showed was in this group of patients, the majority of whom were treated with immunosuppression, you had pretty stable lung function over time and no deaths. And so quite different. And so what was driving that? Obviously, the morphologic pattern was going to be the first thing we looked at. And as I showed in Chicago cohort, we had a high number of patients with UIP, whereas in the Denver cohort, they had a very low percentage of patients with UIP. And I can say now, being at a new institution, we fall somewhere in between. I think Chicago probably has a disproportionate prevalence of UIP, whereas out on the West Coast, we're in the 20% range, and in Denver, they're even lower than that. So I think we're coming to the appreciation that there's a lot of heterogeneity in the prevalence of UIP around the world, and so that's going to greatly influence what we consider IPAF and IPAF outcomes. So anyway, these IPAF criteria, when applied to an IIP cohort, really will result in a different group of patients than when applied to a cohort who's going to be enriched for patients that likely have occult CTD. And then what I'm going to end with is missing data. And so as a data guy, I'm tasked with applying these criteria, often digging through notes. Mary's notes are beautiful. Emery's notes are, just a disaster. And so, so it's very difficult, systematically applying these criteria. And so, show of hands in the room, how many of you seeing patients with ILD get an ANA and a rheumatoid factor on your patients? Get them up. All right, keep those hands up if you also get comprehensive myositis panel on every one of those patients. All right, we're going down a little bit. Keep them up if you systematically assess and document whether they all have or do not have pulmonary telangiectasia. A few more are going down. How many of you say whether they have pulmonary vasculopathy and whether that pulmonary vasculopathy is explained? And so the point of this is having a complete data set is very difficult to come by. And so same thing with your lung pathologist. Are they commenting on these features? And so having a complete data set really does inform how we view these patients with IPAF. And so going back to that survival curve, this is that subtle separation between IPAF and IPF when you have all patients. If you take patients with complete serologic data, that curve starts to shift up towards CTD. And that just goes to show that if you're getting complete serologic data, you probably have a higher likelihood of having occult CTD because somebody's thinking about CTD. And so missing data really are driving a big proportion of what we're considering IPAF. So in conclusion, I think IPAF represents a valuable opportunity to identify a distinct group of patients. We're not there yet, but we will get there. And the way we do it is we first need to decide who are the patients we apply IPAF criteria to. And once we decide on that, we need to stick to it. And then we have to go about identifying these outliers, like the myositis antibody patients that lead to this undue heterogeneity that we're seeing. Also, usual interstitial pneumonia, we need to decide on how to handle these patients. And then ultimately revise these criteria to create a more homogeneous classification. So with that, I will end, and thank you.